Hi everyone, I'm Andrei Purysko and I'm a radiologist at Cleveland Clinic. I serve as the physician leader of the ACR Prostate MRI Image Quality Improvement Collaborative, which is one of the 4 collaboratives of the ACR Learning Network. It is a pleasure to be here today speaking at the AdMedTech meeting, and my goal in the next 10 minutes is to describe the framework, results, and key learnings of the collaborative's first cohort. But first, why prostate MRI image quality? Prostate MRI has made tremendous progress over the last 4 decades, both in terms of hardware and software. We now have 1.5 and 3 Tesla systems capable of generating images with high spatial resolution and capable of probing tissue properties such as perfusion, cellularity, and tissue architecture. And equally important, we have the PIRADS guidelines, which gives us standards for image acquisition and a scoring system for image interpretation and reporting, which allows us to speak a common language. But we also have level 1 evidence from clinical trials showing that MRI improves the detection of significant cancers while reducing the overdetection of insignificant cancers. But outside of clinical trials, the quality of prostate MRI exams has been found to be inconsistent and often unreliable, possibly leading to misdiagnosis of cancer and inability to use the images in subsequent procedures. In a study conducted by the group at the NCI, for instance, they evaluated the quality of prostate MRI exams from multiple institutions and found that 44% of the exams had inadequate image quality. This is very problematic because image quality is the first step in the quality chain for prostate MRI. Problems encountered included poor compliance with PIRAD technical standards, which can negatively impact the reproducibility of the exam, various artifacts such as geometric distortion from rectal gas that can compromise the quality of diffusion-weighted images, and motion artifacts from peristalsis that I'm showing here that can cause blurring of the images. In this context, the collaborative aim was to improve the prostate cancer detection by creating a standardized system for increasing the percentage of MR exams that meet the quality criteria according to the Prostate Image Quality System, or PIQAL. PIQAL uses a 5-point scale in which the score of 1 means that none of the images have acceptable diagnostic quality, and a score of 5 means that all the sequences have optimal quality. For the purpose of the collaborative, we wanted to increase the number of exams that had PIQAL score 4 or greater, in which at least 2 sequences independently are of optimal quality. This is the minimum number of sequences that we need to rule in and rule out all clinically significant prostate cancers. First cohort, we had 6 teams from Advent Health in Florida, Boston Medical Center, Duke University, Intermountain Healthcare in Utah, the Anderson, and University of Pittsburgh Medical Center. In the second cohort that is currently underway, we have 4 organizations. We have Carilion Clinic in Virginia, Cleveland Clinic, Dooley Health from Illinois, and University of Rochester Medical Center. Each team had a project sponsor, a physician leader, a team leader who ideally was an MR manager, a QI coach, and members of the frontline staff involved with prostate MRI exams, such as schedulers. I'm just showing here an exemplary team from Duke University led by Dr. Raj Gupta, who did a phenomenal job in the collaborative. The collaborative framework took advantage of a robust didactic program called Empower that consisted of 10 2-hour sessions in which the teams learned how to use standardized tools for improvement. The didactic sessions were alternated with walk-the-wall sessions for the teams to share their project progress, key learnings, and best practices. And QI coaches receive additional training, and the teams had a chance to schedule one-on-one ad hoc meetings if they need extra help with any aspect of the project. The project used the structured A3 method for improvement. The name A3 comes from the standardized size of paper that was originally used by the Toyota Motor Company to document and communicate with the teams various aspects of the project, such as the goal, scope, and progress. To evaluate the current state analysis at each institution, we first had measure development meetings to discuss quality standards and to come up with a consensus, and that would ensure that we're using the same standards. As I mentioned before, we used the PIQAL system, and we were very, very fortunate to have Dr. Francesco Gigante from University College London to come and give us a webinar. Francesco was involved in the development of the PIQAL scoring system originally. The teams were then asked to audit their images with active participation of the technologists to really try to define their baseline data and also to prepare reference guides that could be used to serve as quality standards to be shared more broadly across the organizations. The teams were then asked to map the entire process of MRI from placing an order to getting the study reported so they could really identify barriers to achieving high quality exams. And we asked them to go and interview the frontline staff and also patients so that they could really have a deep understanding of the process. They organized all the issues they encountered and in this fishbone diagram, and the categories where they met most barriers were protocol for imaging acquisition, patient preparation, and personnel involved in the process. More specifically, as I'm showing here in this Pareto chart, they encountered non-compliance with PIRADS technical standards, geometric distortion of diffusion from rectal wear, and lack of standards on image quality, most common issues across the teams. Supported by the data from the current state analysis, the teams could then define the key drivers necessary to achieve a high-quality prostate MRI, for which they designed interventions that were best suited to improve the process at their own organization. So we did not prescribe any specific solutions. They came up with these solutions by themselves. So for example, for imaging protocol, besides adjusting the protocols to comply with the PIRADS technical standards, some simple adjustments like changing the phase encoding direction from anterior-posterior to right-left really helped reduce artifacts from gas on diffusion-weighted imaging. And these changes really resulted in images with improved spatial resolution and signal-to-noise ratio, which are really important for cancer detection, especially on diffusion-weighted imaging. Very important here to note that these adjustments did not result in an increase in exam time. In fact, in 3 out of the 5 organizations, the exam were shorter, as in this example provided by one of them. The exam went from 48 minutes to 32 minutes, which represents a decrease in 30% of the exam time. The teams also worked on creating patient preparation instructions and methods to make sure patient received instructions on a timely and consistent manner, really to help reduce some of the common artifacts that can degrade image quality, such as bowel peristalsis. You're seeing here an example of a patient with no bowel prep and now a patient with bowel preparations. So really showing improvement or decrease in peristalsis, which can cause blurring of the images. The teams also worked alongside with the techs to develop image quality standards to disseminate them more broadly across the organizations. And also, they really helped the techs recognize and troubleshoot issues with image quality. Here's an example of a patient who did not use the PrEP and had a large amount of stool and gas in the rectum, as you can see here on the sagittal image on T2, and the fusion looks really distorted. The tech appropriately recognized the issue, got the patient out of the table, and after the patient used the restroom, he repeated the images. As you can see, the images not only look much better, but also they made a PIRADS 4 lesion in the right peripheral zone visible. This is a run chart, and it was used by the teams to display the percentage of prostate MRI exams that had a quality PI-QoL score equal or greater than 4 on weekly intervals. We aggregated the data from all the teams to show the collaborative level data. The baseline data from the first 9 weeks before we started any interventions showed that at the collaborative level, 66% of the exams passed the quality criteria, varying from 60 to 74% across different organizations. We started to see improvement after the teams began to test and implement the various interventions using Plan, Do, Study, Act or PDSA cycles, which, as I previously mentioned, mainly address protocol optimization, implementation of patient prep instructions, and technologies training to recognize and troubleshoot the problems with image quality. At the end of the collaborative, we achieved the desired level of improvement. We had aimed for 85%, so at the end we had an 87% of the exams having a PI-QoL equal or greater than 4, ranging from 80 to 97% across the different organizations. In total, these sites evaluated 2,300 prostate exams, which is quite remarkable. For the first cohort, it was not mandatory, but we also encouraged the sites to provide data regarding the DWI, meaning percentage of exams that passed quality criteria for diffusion to be considered adequate. This is because diffusion is really the most important sequence of the entire exam. Looking at the run chart we created for DWI, we can see that the average percentage of exams with adequate diffusion across 3 organizations was 57%, ranging from 47 to 65%. We again started to see some improvement once the interventions began, and the percentage of exams with adequate DWI increased at the conclusion of the program to 80%. So, our work confirmed the variability in image quality and adherence to PIRADS standards across the US. Lack of standards on image quality was one of the main problems, and for that reason, the quality of exams were not being systematically checked. And in order to consistently obtain a high-quality exams, it was really essential to engage the frontline staff in the development of these standards, since they're the ones doing exams. And really, involvement of the techs was a great reason for the collaborative success. Through this work, we demonstrated that improvement can be achieved with the appropriate framework and resources. And beyond the image quality improvement, we showed that participating in the program also had additional benefits in different ways. For instance, there was no trade-off in efficiency, and in 3 out of the 5 organizations, they were able to reduce the exam time. The estimated MRI savings for one of these organizations was 325 hours per year, which can significantly improve patient access. For another organization, the time savings were calculated to generate over $500,000 in revenue annually. So the initiative was also a very positive experience for the overwhelming majority of the frontline staff who participated, and they felt empowered to participate in future improvement projects with the new skills they're acquiring through the program. We're currently accepting applications for Cohort 3. Whether your organization could benefit from an improvement project or if your team is already doing a very good job and could help us develop and disseminate best practices, we would love for you to join us. You can learn more on the ACR website or send us an email. Someone from our team will reach out to you. I would like to thank the Gordon Betty Moore Foundation for their generous support, which made this initiative possible, and many leaders in the ACR, including David Larson, Mildred Chalfield, Judy Bullerson, and many others, who recognized the importance of prostate MRI in patient care, and it made it possible to be included in the ACR Learning Network. I also want to thank the leaders from the 6 organizations who believed in the ACR Learning Network mission and allowed their staff to join us in this inaugural cohort. I'm very, very proud of the work they did. Thank you very much.